Thanks to the GHAPP MASLD Community Network and Madrigal for sponsoring this event. My name is Marcella Pomeranz. I'm a nurse practitioner in GI for almost 9 years now. I work for a large practice in Las Vegas called Digestive Associates. I also work as their lead nurse practitioner, so have a passion for educating. I'm in charge of 12 other APPs, and so I'm super excited to talk to you this evening about our MASLD pharmacotherapy and the options that we have now, which were pretty limited before, and this new exciting things that we can offer our patients to help reduce the risk of cirrhosis. So here's a QR code that we can use to register for this meeting. So let's talk about what's currently available for treatments and what we basically want to focus on. So for patients with MASLD, the first thing we want to control is obesity. And luckily, we have some options for that. So lifestyle and physical activity are always going to be mainstays, and stress to our patients, even despite any other medications that we may prescribe, we're always encouraging lifestyle, diet, and exercise. We have great weight loss medications that can be used, including the GLP-1s now. Bariatric surgery is also a great option for these patients to really help them lose weight fast and reduce their risk of advanced fibrosis. We also want to reduce their cardiovascular risk. So we want to be able to treat their diabetes, their hypertension, their dyslipidemia, and really optimize their other comorbidities to help reduce that compounding synergistic effect of lipid metabolism and fibrosis risk. Then we want to target the inflammation, right? So we'll talk about different liver-derived treatments, vitamin E, pioglitazone, and now resmetirom, which we're really excited about. So what are GLP receptor agonists? So after we eat, we have our own endogenous GLP-1 that helps to stimulate glucose-dependent insulin secretion, suppress glucagon release. It delays our gastric emptying, so we feel full longer, and it directly acts on the hypothalamus to also promote satiety and reduce our energy intake. So the GLP-1 receptor agonists are analogs of our own gut-derived incretin hormone, and they help to lower our blood sugar and also cause weight loss. So how about the GLPs and how it works in our hepatology practice? So a study showed that semaglutide, 2.4 milligrams once a week dosed, successfully met both primary histological endpoints by 72 weeks. So we want to make sure that, one, we're helping to reduce the inflammation without increasing risk of fibrosis. And a secondary endpoint is to help the fibrosis without worsening the MASH. And they met both of these endpoints in this study. We should be considering GLP-1s for our overweight MASLD patients, especially those with more advanced fibrosis. F2 to F3 are great candidates. Not so much for our lean MASH patients, unless they have significant diabetes, endocrinology is watching them, because it will promote more weight loss. So we have to be cautious with that. How does this affect our GI providers? I do think that historically, us GI APPs, we kind of dislike the GLP-1s because we see all the side effects, right? So all the patients that are coming with chronic constipation, nausea, vomiting, worsening reflux, they're coming to us to help manage these side effects so that they can still lose weight, because ultimately that's what's going to help their health the most. We also have to worry about the use of GLP-1s and anesthesia risk. So most of the time when we're booking these endoscopies and colonoscopies, we're telling them to hold these medications a week before to reduce their potential risk of aspiration. For me, one thing I get concerned about with ordering the GLP-1s is muscle wasting. So we know that with GLP-1s, we lose weight, but we also lose muscle mass, and our patients who have advanced fibrosis are also losing muscle mass. So I worry about ultimately having that synergistic effect and really causing extensive muscle mass wasting in these patients. So really encouraging physical activity and strength training to help compound those side effects. Vitamin E has always been kind of up for debate, right? So we dose it at 100 international units per day. These are used for our patients with non-diabetic MASH. They can't have cirrhosis. Also advise caution with hypertensive patients. There was the PIVENS trial that showed that vitamin E improved liver histology as far as steatosis goes in non-diabetic adults with NAFLD. And keep in mind, this is older nomenclature, right? So we don't have MASLD as the nomenclature here because this was an older study. So about 43% of patients showed histologic improvements in steatosis, and inflammation, but not so much fibrosis. Some limitations, not all patients respond. We can't use it in our patients with diabetes, which are really our high-risk MASLD patients, or significant hypertensive patients. In 2023, the AASLD suggested that we could use this to help improve NASH in non-diabetic individuals, but our European liver societies actually do not recommend it as a MASH therapy because it has limited efficacy on fibrosis. There are also potential risks. So with vitamin E, we worry about increased bleeding risk. We worry about prostate cancer concerns. There are some concerns that this in general will increase all-cause mortality. So we have to be cautious when we consider this medication. I have seen some hepatologists recommend 400 international units a day instead of 800, especially for patients who have been on it for a long time and were told that they would benefit, and now they're worried about stopping and the damage they may cause if they don't continue therapy. Pioglitazone, dosed at 30 to 45 milligrams per day, is also used in our MASH patients with type 2 diabetes, but the PIVENS trial showed that there was no benefit over placebo for our histologic features in MASH. However, there were some significant secondary outcomes in cardiovascular risk. So in general, we can consider if a patient has diabetes and MASLD, but should not be used as a primary endpoint of just reducing steatosis or fibrosis particularly. We also have some safety concerns with this drug too. So we want to always make sure patients are aware of potential weight gain and edema, bone fractures, especially in women, and there's a possible association with an increased risk in bladder cancer. So we have to be very careful who we select this particular medication for. So in March 2024, we actually got our FDA approval for resmetirom in conjunction with diet and exercise. We always go back to that as well to help manage our steatosis patients, indicated for non-cirrhotic, non-alcoholic steatohepatitis patients that have F2 to F3 fibrosis. Usually we just need a non-invasive test like a FibroScan to help determine the level of fibrosis in these patients. The mechanism of action is it is a thyroid hormone receptor beta agonist, which selectively binds and activates the thyroid beta receptor in the liver particularly. So it's a liver-specific medication. And it actually works by activating multiple cascades. So we'll see that it reduces our hepatic lipoprotein lipase HMG-CoA reductase that's involved in lipid metabolism, PPAR and SREBF1C will actually increase those because that helps to regulate lipid metabolism. And it also reduces fatty acid oxidation to help reduce the risk of more fatty acids being promoted and developed in our body. So it works from multiple mechanisms in the liver specifically to help reduce the risk of fibrosis. So we have our Maestro NASH, which is an ongoing phase 3 randomized controlled trial of resmetirom with liver fibrosis. And basically this study trialed adults only with biopsy-confirmed NASH with a fibrosis score of F1B, which is essentially F2, or F3. Almost 1,000 patients were randomized and assigned to receive either placebo or either dose of resmetirom, 80 milligrams or 100 milligrams. And we were looking at 2 primary endpoints by week 52. So if you're not familiar, the NAFLD activity score or NAS score actually is a liver biopsy score that shows how much ballooning, how much inflammation is going on. So the first endpoint showed NASH resolution with a reduction in the NAS score by greater than or equal to 2 points with no worsening of fibrosis, and also an improvement or reduction in fibrosis by at least 1 stage without worsening the NAS. So very similar to the semaglutide study, we want to make sure that one is not worsening the other, that we're improving fibrosis without worsening inflammation, and we're improving inflammation without worsening fibrosis. So the study showed that there were just some mild side effects for patients. Diarrhea and nausea were more frequently reported, especially in the first 1 to 2 weeks, but I do feel it does level out over time. The incidence of serious adverse effects was similar across all trial groups, which shows the safety and tolerability of this drug. So the Maestro NASH phase 3 primary endpoints showed that resmetirom 80 milligrams and 100 milligrams were superior to placebo with respect to NASH resolution and improvement in liver fibrosis by at least one stage. So this was remarkable. By 1 year, we're improving that stage by at least 1 point. So you'll see the NASH resolution was 25 to almost 30% compared to 9.7%. And then the fibrosis improvement, we have about 24, 25% compared to 14. So what are some practical considerations for managing MASH with resmetirom? We want to find that ideal patient for treatment, right? Adults with non-cirrhotic MASH with stages F2 to F3. We always want to be promoting diet and exercise. We want to make sure alcohol is not a considerable factor here. We really have to handpick our patients. If they have like an F1, they may not qualify for this drug. We also need to be cautious of some medication interactions. So particularly all the way on the left, some medications that we need to avoid. Gemfibrozil we see sometimes with these patients. Clarithromycin we're ordering for H. pylori and other things in GI. So those are just some examples of things that I always keep an eye out for. When we're ordering this medication and a patient is on Plavix, we actually want to reduce the dose of resmetirom. So in general, I use the 100 kilogram rule. 100 kilograms or over 100 milligrams. If it's less than 100 kilograms, use 80. But if a patient is on Plavix, then we reduce those doses by 20 milligrams. So if they're under 100 kilograms, do 60 milligrams. If they're over 100 milligrams, then we'll do 80 milligrams if they're on Plavix. If they're on pioglitazone, then we want to make sure that they're taking a maximum of 15 milligrams per day, not that 30 to 45 that we saw on a previous slide. Also cautious with montelukast because I feel like that's a common medicine that we see in our clinics. We also need to be advised that since this medication works multifactorially in reducing lipid metabolism, it will lower our cholesterol, right? So we have to reduce our statin therapy to make sure that we're not lowering cholesterol too much. So here's a picture on the maximum doses that we should be using for different statins with resmetirom. So practical considerations for managing MASH with resmetirom. We want to make sure we're watching them during their treatment and we're monitoring. We still have some ongoing data that we're collecting from the Maestro-NASH trial. We're going to be wanting to pay attention to their fibrosis and steatosis scores using our non-invasive tests. So we have our transient elastography, the MRI. We can even use ELF scores. I always say to always use the same non-invasive test as you're monitoring these patients. Because, for example, a transient elastography and an MRI both report in kilopascals, but we're comparing apples to oranges, right? You can't compare elastography to MRI results. And then expert panels are currently working on cut points and giving us some guidance on how often we need to test our patients and basically helping us determine when we should be stopping our therapy as well. So some questions that remain, insurance coverage we always worry about, but I am finding that it's getting much more covered as it's been out for a longer time. Periodicity of staging and lab testing for monitoring. In general, I'm checking every 3 months in these patients and repeating my non-invasive test yearly, but maybe we need to be doing it more frequently. We'll need to discuss treatment recommendations and when to discontinue treatment. One patient, a clinical question came up where they had a patient that was on resmetirom and their FibroScan was actually getting worse, but they admitted they had gained 40 pounds. They had lost a family member that year. They really weren't working on diet and exercise. And so they asked me, should I be discontinuing this drug because the elastography readings got worse? And I was like, well, I don't think it's only the drug that made these readings worse, right? So maybe we should be really promoting diet and exercise, keep them on the drug and just keep a closer eye on them. And I wouldn't discontinue just yet because it seems like they're going through a pretty drastic time in their life. And we know that weight gain is going to drastically make these non-invasive tests worse, right? So luckily, we also have multiple agents that are currently in clinical trials. So I do think, in the horizon, we have other options that we'll be able to offer our patients, and which is great because, a couple years ago, we didn't have a lot. So it's exciting to see these new drugs in development. I encourage all of you to visit the GHAPP MASLD Community Network for additional education and listen to the Rezdiffra webcast. Here's the QR code for that. And then if you have any feedback, I'd love to hear your insights. We're always looking to improve. Anything that you feel we're missing from our presentations and you want us to address, we're happy to take any feedback.